and become proficient in the use of the criteria, and especially be aware of some of these changes that we're going to be talking about today. So let's get going here. Hold on a second. In terms of introduction here, I'm going to be talking from some of the text that is in the introduction to the DSM-V. So this will be familiar to you if you've been through that, and it'll look familiar to you when you go through it. I want to emphasize that this is not a training on these changes and how to do diagnosis. Diagnosis really does require clinical training and expertise in order to determine those diagnoses. And additionally, the use of these diagnostic criteria requires clinical expertise to differentiate from normal life variation and transient responses to stress. Any one of these criteria in and of themselves is not sufficient for a diagnosis. It really is a cluster of these that will allow you to be able to make a competent diagnosis. As such, the case formulation for any given patient has to involve very careful clinical history, including collection of data to support the criteria and to really learn about who you're assessing here. Concise summary of that social, psychological, and all of the biological factors that could have contributed to developing any given mental disorder, but substance use disorders in particular. These diagnostic criteria in DSM-V are offered as guidelines for making diagnoses. Their use should be informed by clinical judgment. This is one of those areas of competency that substance abuse clinicians, chemical dependency counselors should have as part of their training and experience. Even to become a proficient clinician, you have to have had this training somewhere along the line. Following those following the assessment of diagnostic criteria, clinicians need to consider the application of those disorder subtypes and or specifiers as appropriate, and this includes things like being in remission, partial remission, full sustained remission. Again, these are, if you're familiar with DSM-IV, those are familiar terms. There were some minor changes in there, but you do need to use those in addition to looking at the specific criteria. And the general convention in DSM-V is to allow for multiple diagnoses to be assigned for those presentations that meet criteria for more than one DSM disorder. So co-occurring disorders is an example where someone could have both a substance use disorder and another mental health disorder that can be existing at the same time. People can also have more than one substance use disorder depending on the substances, alcohol dependence, for instance, or excuse me, alcohol substance use disorder, and also have one with methamphetamine or cannabis or nicotine. Any one of those can be co-occurring. In terms of the changes between DSM-V and DSM-IV, one of the major changes here is in the multi-axial system that was used previously in DSM-IV. Despite its widespread use and its adoption by insurance and governmental agencies, that multi-axial system in DSM-IV was not required to make mental health disorder, mental disorder diagnosis. Although it's been utilized in that way, it was never intended to be, and it really wasn't necessary. So what DSM-V has done is move towards a non-axial system. And what that means is that those life conditions that you would have seen typically in axes 1, 2, and 3 in DSM-IV no longer exist in DSM-V. Those have all been combined. And there's no axes at all, really. But if you're familiar with those, you want to, you'll still be using them, you just won't be using them as separate axes. Clinicians should continue to list medical conditions that are important to the understanding of or management of an individual's medical disorders, and if you're using the sort of the companion piece to this, which is ASAM patient placement criteria for placement, you would still use those dimensions there, and medical conditions would be dimension 2 in terms of placement. So you want to use this in conjunction with other clinical tools, with placement criteria, and certainly with knowledge of the specific patient and their presentation. Another major change here is the GAF scale, or the General Assessment of Functioning. DSM-4 Axis 5 previously consisted of this GAF scale, probably very familiar to most people. This represented the clinician's judgment of the individual's overall level of functioning, and this was within a hypothetical continuum of mental health and mental illness, ranging from, well, probably no one had a 0, but it went all the way up to 100, and it was really very subjective, very clinician controlled in a way. Two clinicians could look at the same data and have relatively different levels of functioning. So GAF was dropped from DSM for several reasons, including that conceptual lack of clarity and the questionable psychometrics, those inconsistencies between clinicians and how it was how it was being applied. More changes. The names of the disorders and the symptoms needed to diagnose those conditions are probably the most significant change that you would see in the substance use disorders, the substance-related disorders. We'll go through those now. The biggest change you'll see is that the terms substance dependence and substance abuse are no longer really diagnostic categories. Those
Go. Julian, we can't hear you. I don't know if your mic's out.
Julian, I believe your microphone has been unplugged. So folks on the line, forgive me, your Julian is currently offline. His mic is not lined up. We are working on that. We're waiting for Julian to come back online. If folks do have questions that they would like to ask during the course of the conversation, please use your chat box, and you can get the questions to us, and we will be asking them at the end. Thank you very much for your patience. Julian is working on getting it back on again. Julian?
I'm here. Do you hear me now?
Yes.
Hello? Yes. Can't hear me now again?
Yes.
Okay. All right. Sorry, I don't know what happened there. It suddenly just stopped broadcasting. Okay, so we're back to the slideshow here. Those two conditions are now combined into one condition called substance use disorder. So there are not two separate conditions. It's now one condition on a broader continuum than what we had before. The combination of those two that were formerly called substance dependence, substance abuse, means that they are no longer really valid diagnostic categories. People should stop using those terms and transfer their language. Just be aware of it. people are no longer dependent or abusers. They are persons with substance use disorder. The number of criteria used to diagnose, previously there were 11. It has changed. There's still 11, but there have been a couple of changes, one subtraction and one addition. Previously there were 4 separate substance abuse symptoms that were diagnosed separate from the dependence criteria. The usual protocol was that you look to see if the criteria for dependence were met, and if they were not met, then you looked at the 4 criteria for substance abuse, and the person only needed to meet one of those substance abuse criteria in order to be diagnosed with substance abuse. The 7 substance dependence symptoms needed 3 out of the 7 in order for there to be a diagnosis, and it could be any 3 of the 7, and it included both physiological and psychological symptoms. What we see now is a change in the number of symptoms that are needed to have a diagnosis. Now there's a minimum of 2 of those 11 symptoms have to be met in order to diagnose a substance use disorder. 2 to 3 symptoms, which would be the mildest of the conditions, would mean it's a mild substance use disorder. This would correspond roughly to what was being called substance abuse previously. You'll see we'll talk about the different symptoms, but the symptoms are in DSM-V get progressively more serious as you go up into the more severe condition. So 2 to 3 symptoms to diagnose mild substance use disorder. 4 to 5 of the symptoms of the 11 symptoms are needed to diagnose moderate substance use disorder. This would be the beginnings of what would be the substance dependence categories in DSM-IV. And then 6 or more symptoms would be severe substance use disorder. And this would definitely be in the substance dependence category under DSM-IV. One substance use disorder symptom is new. It's cravings. This has been added to the combined substance abuse and substance dependence symptoms, and one former substance abuse criteria, the recurrent substance-related legal problems, has been eliminated. So we still have a total of 11, but 10 of them are the same as before. 1 has been eliminated, 1 has been added. Cravings were seen as an important symptom, and were added as a criteria because it is something that we see very commonly. It's characteristic of most substance use disorders. The elimination of recurrent substance-related legal problems was, I think, appropriately taken out because it's based on a legal condition. Depending on which state you live in, you may or may not meet this criteria based on state laws, and the committees that looked into this figured, well, you should not be able to be diagnosed with a condition, mental health condition, and that condition disappears if you cross the state line into another jurisdiction and the behavior is no longer illegal. So because of that, I think it was decided that it was not an appropriate criteria and it was eliminated. Again, I think most people would support that and support the introduction of cravings as an additional criteria. Criterion A grouping, these are the criteria in the substance use disorders, the primary ones, the diagnostic criteria, if you will, are grouped into sort of severity groups. The impaired control would be criteria 1 through 4, and these are often what would have been considered the criteria for substance abuse. But impaired control simply means the person is losing the ability to manage their own use of the substance. Social impairment means it's having an effect on their interactions with their community, with their job, their family, relationships, and those criteria 5 through 7. Well, let's go through them. Criteria 1 through 4 would be that we'll use as an example alcohol use disorder, is that it's taken in larger amounts over a longer period than was intended. 2 is that there's the persistent desire or unsuccessful efforts to cut down or control use. 3, a great deal of time is spent in activities to obtain alcohol or recover from its effects. And then 4 is the craving. So impaired control criteria 1 through 4. Social impairment would be recurrent use and resulting in failure to fulfill major role obligations. This was previously a substance abuse criteria. Continued use despite having persistent or recurrent social interpersonal problems caused or made worse by the effects of this substance. And then important social, occupational, recreational activities are given up or reduced as a result of the use. Here, these items are having a social impact on the individual, not just about their ability or inability to control their use, but the effects of it on their life in general. The risky use would be criteria 8 and 9, that is, recurrent use in situations in which it's physically hazardous, such as driving while intoxicated would be probably the best example of that. And then alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that's likely to have been caused or exacerbated by alcohol. And what is commonly seen here for people who are in recovery, resuming use would be seen as no longer being in full sustained remission because of this here. They're using a substance that they know has caused them physical or psychological damage and continue to do so, or they have resumed the use, risky use. And then there's the pharmacological criteria tolerance, number 10, which is a need for markedly increased amounts of alcohol to achieve the same effect, or a markedly diminished effect with continued use of the same amount. Tolerance is one that is often also misunderstood. What this criteria is talking about is a change over time in the tolerance to a particular substance. It's not that the person has the ability to consume a lot of it. There's 2 types of tolerance. There's tolerance saying this person, because of their physiological makeup, has the ability to consume a lot of this substance, where someone else with a low tolerance may not be able to consume as much. Then there's the tolerance that is talked about here, which is change in tolerance over time. A person who previously took a small amount of the substance to have a desired effect now has to consume much more of the same substance to get that same effect. That's the change in tolerance. That's the criteria that we're looking at here. By the same account, the diminished effect is a person continues to use the same amount as they were before, but they feel a diminished effect. The effect doesn't have have as profound effect as it did previously. Number 11, the last of the physiological symptoms, is withdrawal, and there are characteristic withdrawal syndromes for different substances, including alcohol, methamphetamine, and one that has recently been added in this edition of DSM is one for cannabis. Cannabis was not previously included, I believe primarily because there wasn't a lot of research on cannabis withdrawal, but there is sufficient now and it is included in here. And then the other element of withdrawal is that that substance or another closely related substance is taken in order to avoid withdrawals. So withdrawals occur not because of intoxication, but because they are no longer intoxicated, and then the withdrawal effect is what you're seeing there. This is why people will sometimes take the substance in order not to get high, not to get the drug effect, but simply to forestall withdrawals. And that's what you see in what were in the past called maintenance drinkers, and it's what is often seen in opioid use. The great majority of people using heroin are not using it to get the drug effect anymore. They're doing it primarily to avoid the withdrawals. And then in this section 2, there is some discussion in DSM regarding remission. Early remission would be after the full criteria for the disorder were previously met. None of those criteria are present for at least 3 months, but for less than 12 months. This is a change from DSM-IV, which had 6 months as the cutoff. And then sustained remission would be after the full criteria for the disorder were previously met. None of those criteria have been present at any time during a 12-month period. So 12 months is the cutoff point for sustained remission. So these represent probably the most profound change, and the one that I think people need to become most familiar with in DSM-V. It's going to affect the outcome of the assessment, the diagnosis, and likely the placement as well. One of the things that really has to be paid attention to here as well is in tolerance and withdrawal, those physiological symptoms, is that symptoms of tolerance and withdrawal that occur during appropriate medical treatment, such as opiate substitution treatment, with prescribed medications are specifically not counted when diagnosing a substance use disorder. So there are many substances that cause, to which people develop tolerance and from which they will experience withdrawal. When it's part of appropriate medical use of a prescribed substance, then those symptoms cannot be used as a way of diagnosing substance use disorder. If there are additional criteria met, some of the other 11, then certainly they can be included in that. But these alone are not appropriate. The appearance of these normal expected tolerance and withdrawal during the course of medical treatment in the past has been known to lead to erroneous diagnosis, even when those were the only symptoms present. So tolerance and withdrawal alone are not sufficient to diagnose a substance use disorder. So what do these changes mean? Well, substance-related legal problems are no longer sufficient to diagnose a substance use disorder. This is a pretty big change, especially for people in the legal system who have been accustomed to seeing legal problems as a primary criteria for diagnosing these conditions. That's no longer going to be the case, and I believe appropriately so. It also means that people who are being sent to an outpatient treatment service based on the diagnosis of substance abuse could now be referred only to Alcohol and Drug Information School. This is education, not treatment. If they meet only one criteria of what was formerly substance abuse, they would no longer meet that threshold for being sent to treatment. They would still need to be, they would be sent to education. Now, if they meet more than that, if they have mild, moderate, or severe disorder, they may be sent to outpatient or in some cases residential treatment as well. People who have recurrent use in situations that are hazardous to themselves or others meet one of those, the minimum of 2 criteria, of 2 symptoms required to diagnose substance use disorder, as opposed to only needing having to meet one previously under substance abuse. Having one symptom of substance use disorder isn't sufficient to diagnose the condition. This is a significant change here, especially in terms of treatment that's recommended for legal issues. Probably the most common legal issue that people get sent to treatment for are driving while intoxicated and maybe assault or domestic violence. They're common. In the past, recurrent behavior in that one area could result in treatment. In this case here, it might not. People who were previously diagnosed with substance abuse would still be referred to outpatient treatment if they meet the diagnostic criteria for mild, which would be 2 to 3 symptoms. Meeting one symptom is insufficient, so that person would be referred to Alcohol Drug Information School. People who were previously diagnosed with dependence will still be referred to participate in treatment, not education. There really is not much change in the treatment recommendations that would be expected for moderate to severe substance use disorder, so you probably won't see as much of an effect here, but hopefully it would result in better placement in those treatment levels of care in the ASAM criteria, which would be levels 1, 2, or 3. The idea is that better diagnosis would result in more appropriate, more effective placement in the proper level of care. Diagnosis of substance use disorder cannot be made only on based on the presence of pharmacological symptoms, and I know that for many providers and for many people who have well, maybe question the validity of treatment with pharmacological substances such as methadone, which is probably the most common one, that or Suboxone. These are commonly used substances in the substance abuse treatment field. Tolerance to those substances alone is not enough to say the person is in relapse, is not in remission, or is in some way intoxicated. It's still a controversy even over the last 20 to 30 years, perhaps less so now, but there are still plenty of people who don't believe in the use of pharmacological substances to treat substance use disorders. But it is common, it is accepted, it is happening out there, and the reality is that our attitudes, those of us who have that belief, have to change with the times and to understand that it's not based simply on beliefs. This is research-based, this is evidence-based changes that were incorporated into DSM-V. We have to look at what is expected when someone is taking a medication. If that medication includes tolerances and withdrawal as part of its characteristics, then we cannot use those as a way of diagnosing a mental health or substance-related disorder condition. There are already multiple systems that have adopted the use of DSM-V. The Washington State Department of Licensing has already adopted this in the use of in the categories that are used on the assessment and treatment reporting form, often called the blue form. This is used to report assessment and treatment compliance to the Department of Licensing for people who have DUI convictions. So Department of Licensing has already moved ahead in implementing DSM-V. DBHR agencies were required to implement the use of DSM-V as of September 1st, 2013. Now there is an exemption in fact for Medicaid billing using DSM-4TR, and so what this means is that for those programs that do Medicaid billing, they can use the billing codes in DSM-4 to get reimbursed for payment. But that does not mean that they should not be implementing the clinical aspects of DSM-5 into their clinical program. It's critical to be well into this by now. This exemption will expire at the end of October in this year regardless, and ICD-10, the international criteria, will be in effect. So it's really essential for programs to be implementing these changes right now. If you have questions about the exemption or what these mean, you can always call us here in certification. You'll have my contact number at the end of the presentation. Be glad to talk with you about those. But do start moving ahead with implementing this if you haven't already. It's really critical. So what's next is that our certification licensing survey staff will be reviewing certified programs for compliance with these diagnostic criteria. We're doing it now. We're providing people with technical assistance, sample forms when they're available and when programs wish to use them. But this is happening now, and we are conducting those reviews as we speak. In addition, agencies, administrators, and chemical dependency professionals will be held accountable to make clinical decisions based on these criteria, as they will be for others such as the ASAM patient placement criteria. Both of these are critical to accurate diagnosis and placement, and we are looking to see that programs and clinicians are compliant with those. Because we are ourselves chemical dependency professionals, all of our survey staff, we also have to ensure that those people who are not doing this, depending on the severity of it, could be reported to the Department of Health. Compliance with these criteria is mandatory. It's not optional. Failure to comply does result in deficiencies, and we do require corrective action. So in terms of additional resources, there were a few things here I wanted to, I'll go back. Here, this slide may look a little bit different than what you have previously. We made some adjustments to it. There are some other resources available for you if you're interested. And the transition to ICD-10 is a document that is provided by, hold on. Let me move this over for you. I have this on another screen here. I'm trying to move it over so you can see this. Hold on. This is the transition to ICD-10 and what it entails and why it's important to behavioral health providers. The link that you see here, the top one on the slide, will take you to this on the APA side transition. So it tells you what ICD-10 is, why it's being substituted for ICD-9. October 1st, 2015 is the implementation date, and it's a one-page sheet. It's important for you to be aware of it. I'd encourage you to do this if you're billing or plan to bill Medicaid. Another link here is to the APA education site, which is a good resource. The third bullet down here will take you to a specific training. And if you want to get training specific to DSM-5, I would suggest this one down here that says New DSM-5, what you need to know. Click on that one, and that's this course here. This is, I believe, a 6-hour course. You can get continuing education for it. it will give you much more proficiency both in substance use disorders, but DSM-5 in general. And then the final one here is for continuing education credits. You can see there are costs for these. This one's $249 because of the continuing education credit. This one here for $199 is with no credit, and this transitioning to DSM and ICD-10 is the PDF that I showed you before. Again, I encourage you to take a look at these, get additional training, become familiar with them, get a copy of this of the DSM-5, and certainly read the introduction, become familiar with the changes, and then get training in order to become proficient in order to utilize it in your clinical practice. So here is, that concludes the slide presentation. Here is the contact information for me. This is my direct phone number, 360-725-3730. The toll-free number will get you to our DBHR receptionist, and she will be able to forward you to me as well if you need to use that one. And then you can always use email as well. I encourage you to visit our website. We have a lot of information there, and hope that this presentation has at least given you some idea of where to start in getting your training in the future.
Thank you so much, William. We have we do have some questions. Folks in the field. Again, as a reminder, because they are going to be asking questions, we encourage you to put your question in the chat box, and we'll be getting those questions in the sequence we've got. So the first question coming in is, with the Division of Abuse and Dependence Diagnosis, there were limits on funding treatment for people with abuse diagnosis unless adolescent and pregnant or early parent. With the new SUD, do you see more funding for people with 2 to 3 symptoms?
Well, this is an area that's currently under discussion, and it's really a budget issue